Welcome to this special BMJ podcast episode. This is one podcast in a series we've been doing for one of our collections on quality of care in collaboration with the WHO and the World Bank. I'm Emma Veach, one of the BMJ editors, and I worked on this collection from the editorial side.
And I'm Rachel Hinton, another editor at the BMJ. Making healthcare safer and better is important in every hospital and clinic in the world. But no matter where you are, improving healthcare quality relies on quality data. But that data is often hard to collect and use without the time and expertise to do it. So in this podcast, we wanted to show how different healthcare systems, despite being some of the most constrained for time and capacity, are tackling the challenge of collecting and using data head on.
Today, we're joined by an author of a BMJ paper on that topic, Ambrose Aguayu, here in discussion with Reham Nigmeldin and Jafet Arrieta.
Hello, everyone. My name is Ambrose Aguayu, and it's a huge privilege to be here today. I'm a pediatrician and professor of infectious disease epidemiology, working with the London School of Hygiene and Tropical Medicine, based at the Kemri Wellcome Trust Research Program in Nairobi, Kenya. My work spans pragmatic clinical trials, epidemiology and surveillance, and implementation science with a focus on quality of care. Huge pleasure to be here. Thank you.
Thank you very much, and it's my pleasure to be with you today. I'm Reham Nigmeldin from Hamad Medical Corporation from Qatar. I'm working in Hamad Healthcare Quality Institute, which is an institute that's focusing around building capacity and capability for better quality and safety of healthcare in our organization. And we also run different collaboratives that focus on improving clinical outcomes.
Hello, everyone. It's a pleasure to be here. My name is Jafet Arrieta, and I'm a vice president with the Institute for Healthcare Improvement. IHI is a non-profit global organization working to improve health and healthcare worldwide, and it's an honor to be here with you.
So let's start with the difficulties. Quality improvement is a huge topic, and we can't address it all. Our focus today is on measurement and data collection. Ambrose, you're working in Kenya where the burden on clinicians to just provide care is huge, and yet you're managing to collect good data and make improvements. Can you tell us about some of your challenges?
I'm very lucky to be part of a large team that's been involved in work that's been taking place for almost 10 years now, in a platform that's been running in Kenya called the Clinical Information Network. And so this platform brings together healthcare providers from now 26 public hospitals in Kenya, all coordinated with a core team of researchers and data analysts and administrators. And this platform integrates data collection, routine data collection, into everyday clinical practice, allowing us to gather high quality data without overburdening healthcare providers. And I think that point is really critical, and I hope we'll be able to come back to it. This tension between the needs for program managers versus frontline providers who are responsible for collecting that data. These frontline providers are often working under extremely busy environments with large queues, and ensuring that they capture data completely is one of the gaps that needs to be addressed, and particularly in the environment where we work, where care is typically delivered by junior clinicians who are often on 3 to 4 month rotations. And so, every quarter there's a new batch of junior clinicians who need to be oriented around these tools if you're to ensure that these gains are sustained. And then I think the other issues really are system level. It makes no sense to expect a frontline provider to adhere to guidelines for pneumonia or diarrhea or malaria when the equipment and treatments and diagnostics are unavailable.
Jafet, the IHI is synonymous with healthcare improvement, and you must have seen challenges like those that Ambrose was talking about a lot in your experience. Can you talk to us about that from a more high-level system perspective?
I will say that if I had to categorize them, I would say that we face technical challenges and adaptive challenges. And the technical challenges Ambrose spoke to, the challenges that we see at the facility level, there is a lack of infrastructure or very limited infrastructure. We've seen that many countries, particularly low income countries, but also some middle income countries, still rely on paper-based systems, that leads to duplication, that leads to some of the challenges that Ambrose was speaking to, right? Like incomplete data or low quality data that you can then not necessarily rely on to guide decision making. So there's the infrastructure piece when it comes to the data systems themselves, the technology. On the technical side, again, there is also limited capacity and capability. Ambrose, you spoke to that at the facility level. That holds true at the systems level as well, where you oftentimes don't have the people that have the capacity to collect the data, analyze it, visualize it, and then provide feedback to the people that need to get that feedback at the facility, at the district level, at the provincial level to act upon it. And at the end of the day, what we've seen is that oftentimes the priorities and the strategies do not necessarily respond to the local needs because there is variation at the subnational level. One of my professors used to say that the mean hides a lot, and that's true, right? And that's why I think it's so important to, in our dashboards, when we share the data, as we create those feedback loops, it is important to stratify, to slice and dice the data, to stratify the data by sociodemographic characteristics, by system level characteristics, to help us better understand where the opportunities and the gaps and needs are, the complexity and fragmentation of health systems. And then on the adaptive side, the resistance to change that, in my experience, plays a huge role to drive change.
Riham, you're in Qatar. Do you recognize the kind of issues that Ambrose and Jafet are talking about?
So Ambrose is focused on infectious diseases. On their side, we're more into non-communicable diseases and harm prevention. But whatever it is, the challenges when it comes to data collection and measurement are classic. I mean, I guess Jafet kind of summarized those into the technical and adaptive challenges. They're exactly like this. I mean, every organization would typically go through those challenges in the journey, as you said, from measurement up to action and change. We've been going through a partnership with the IHI for the past 10 years, for instance. Our first earliest collaboratives was on harm reduction. So we were focused on sepsis prevention, on venous thromboembolism prophylaxis. And we started by just the data generation part. Okay, what kind of data do we have in the system? And as Amber said, it depends on what gets entered and documented. So there was a time where we were stuck just encouraging people, just document so that we can get something out, and then how can we start looking into the quality of the data that's being entered, even if we don't start by automation early on, but staff need to be good with even using a paper and a pen. And we do encourage them to run charts with a paper and a pen. We tell them you don't have to depend on anything, just do it. Okay, if you have a couple of data points, do it. Because again, talking about action, there's nothing better than a staff putting a piece of paper up there on a visual management board and moving their own dots. This is what encourages action from within. This is what gets staff to be passionate about the measurement and makes them engaged and willing to improve even their techniques when it comes to data collection. One big thing that drives action also is building capacity and capability. And I think it's so hard to engage physicians in something like data collection. And one of the biggest factors that would disencourage them and demotivate them is the fact that they don't know a lot about the data management science itself, and they would be embarrassed to confess it. So there needs to be a way of approaching frontliners, whether the junior ones, the senior ones, okay, and try talking to each one of them and what is their needs when it comes to building capacity and capability and training around different measurement skills.
Wow.
This is cultural change. This is huge, but it takes time. It takes a lot of time, okay? And it needs consistency, and it needs open conversations, transparent ones, okay? And as long as you reach out again to people with training and building skills, it's gonna happen.
Ambrose, Raham mentioned capacity there and the need for them to build it. What does capacity building mean for you in Kenya?
I think for me, the area around capacity is is critical, but sometimes I think we're missing the point when we talk about capacity. And I say this from the context where I work. We need to stop expecting miracles from healthcare providers who are already extremely overburdened. So in the conversation around capacity, I think the first point needs to be around ensuring that there are more individuals who are trained to support not just the frontline healthcare provision, but also, the data management and also the leadership and management aspects around data use. In some cases, you can find that the reports that they receive from around quality of care are used for punitive purposes, which is, a big shame. So there's soft skills around leadership and management that are required, that need to be developed. And then I think Reham has already talked about lack of awareness around data management and analysis and interpretation among frontline providers. This is just not trained in. Perhaps would require more attention from actors across the health, but also the education sector, where a lot of this pre-service training is delivered.
Reham, when we were chatting before today's recording, you talked about measurement moving beyond a focus just on safety and towards things like more person-centered approaches, considering things like the clinician's experience in providing care. Could you tell us more about that?
Thank you very much, Emma. I guess the measurements that you've kindly mentioned with regards to patient experience, person-centered care, joy at work, staff satisfaction and engagement, they're kind of a sign of maturation in the system. So as you said, once the team has fulfilled the typical performance safety measures, they've looked into outcome and process measures, they need to be attentive to their own capacity. And one big evolution that we've been seeing is that as much as we've encouraged them to measure their own satisfaction and their own joy at work, they started linking that even to their performance and safety. They look at the other week we were attending one value improvement huddle in one of the medical wards who've been working on value improvement for the past 6 years. They're one of the leading spread units, and the team there were reporting on a project where they're giving the care for bedridden patients and linking this performance measure to their own satisfaction with the care. So this was for me the tip of the iceberg, let's say, because it's a great opportunity to show that you can link safety of the patients with the happiness and the satisfaction of the staff, who will find themselves being confident more if they're offering better care for their patient. And it's a simple tally count, okay, that they keep notice of how they feel around their work environment on daily basis. So how can we have this again embedded? And they select their own ways. And we've had teams being very innovative. We've had them using QR codes to collect those through their mobile apps. So a quick click on their mobile and they submit in their interaction of the day and how they felt. And we've opened the door for qualitative data also. And as much as staff were a bit silent and shy at the beginning, you would be amazed how much they would give feedback and valuable feedback as they're given a good channel to do that. It happens during huddles, and those most silent frontline who are shy start jumping in and giving ideas about care, or expressing how they're not confident about this task or that way, or that they've seen a different practice during their orientation in the next door ward and they would like to steal shamelessly and start trying and testing this on board. The teams find great satisfaction in taking ownership of work and measuring their own selves in the way that they want to do it.
Jafet, you're nodding along there. I wonder if you'd like to come in here and tell us a little bit more about a project that you've worked on that's really, brought all this together and improved the health of patients.
It's really hard to pick just one example, but I'm going to try to answer your question and illustrate some of these concepts and some of what works using a particular example from my work, and that's the Golden Hour Collaborative. We launched that with the aim of increasing the percentage of children with cancer who develop fever and present to the emergency department and receive the first dose of antibiotics in less than 60 minutes. And that's because we know the evidence tells us that if those children who are at the higher risk of developing fever, infections, and then dying of infections and sepsis, receive the first dose of antibiotics within 60 minutes, that reduces the likelihood of dying and developing complications. And yet, what we learned through our partnership with St. Jude is that only about 40% of children in Latin America in the hospitals that we were working with were receiving that first dose within 60 minutes. So we partnered with 85 hospitals from 6 Latin American countries to around the same aim, increasing the percentage of children who received the first dose of antibiotics within the golden hour, within those 60 minutes. So I think the main thing that I will say in terms of what works is having a galvanizing, inspiring, motivating aim that people can get around. Based on what we learned, we drafted a theory of change that included 5 key drivers. The first one was around the enabling environment, creating the enabling environment, making sure that teams had the supplies that they needed, right? Medications, which was a huge issue. And then the second driver was around data management and learning. Right. And so we put it front and center. We said we need to work with these teams to establish a data management and learning system. But then we also knew that we needed to be able to track some process level indicators related to the processes that we were trying to improve, right? Such as time between triage and antibiotic prescription, time between antibiotic prescription and antibiotic administration, of course. And then the other 3 elements that I think are key for successful improvement work are around 3 other drivers that we worked on. One was process reliability, focusing on improving process, both clinical and paraclinical processes reliability, working closely with clinicians, building that capacity and capability as well where needed. And then one more element was around patient engagement. And then the last driver that has been that Reham spoke about was promoting teamwork, effective communication, and really trying to change the culture, promote a culture of quality within the institution, not just the teams that we used to work with. We saw an increase in the percentage of children that received the first dose of antibiotics during the second phase within the first hour, from 47% to 75%. And that resulted in a 60% decrease of sepsis. And one thing that I always like to remind my teams of, and that we have highlighted with the teams that we work with, is the fact that behind each data point, when we look at percentages, there are patients, there are lives, there are families. And not to say that it has been easy,
No.
And it has been successful.
Okay, so we're almost at the end of this podcast, but it would be great if you could just give our listeners now a single takeaway point from all your experience.
My number one takeaway message: it's a journey. Staff need to know that it's not going to be hard or an easy sail, but it's enjoyable and worth it. And the more they believe in it and they feel benefit and win and their own personal ownership and leadership, it's going to work fine. And we need to be patient. On the other side, people who are working at the executive quality side, they need to be very understanding and patient.
My personal call to action really centers around investing in the health system. And for purposes of this discussion, it's really the health workforce who are the face behind the systems which drive quality improvement. We need to ensure that we have enough trained and motivated healthcare providers. And this includes both clinicians, nurses, and also the health records personnel who are responsible for actually managing that data, ensuring that they have competitive salaries and creating supportive working environments. Because even with the best systems, you would fail to achieve the full potential of measurement for quality improvement. So I think investing in the health workforce can deliver better care and also drive that culture where data is used to drive improvement.
Thank you, Emma. So I will invite folks who are listening to first ask yourselves what matters to you and what matters to the patients, the families, the populations that you serve, and to use the answer to that question to give you purpose and to help you connect with that meaning. Because in my work, constancy of purpose is key and the rest follows. And then as you move from purpose to action, I would say start where you are and with what you have. Change can be affected, yes, top down, but also bottom up. And as you work with data to affect and drive change, seek ways to make meaning of the data and go full circle and align that with what matters to you, what matters to the patients and the populations that you serve. You are agents of change, and change starts with each of us, and of course with our system leaders.
A big thanks to Ambrose, Reham and Jafet. I hope you enjoyed listening to this podcast and see that the experience of improving quality has the same challenges and gains wherever you are in the world. This is the second from BMJ in a series linked with our Quality of Care collection, which we developed in collaboration with WHO and the World Bank. Those papers in our first podcast are available at bmj.com/quality of care. We'll be back soon with our third and final podcast on quality of care. But before then, the BMJ's editor, Kamran Abbasi, will be back with our regular BMJ podcast. Bye for now.